Hi, everybody. Well, I wanted to thank you guys for joining tonight. My name is Dr. Paul Knoll. I'm here. I'm a native Nashvilleian, and I wanted to talk to you guys about two important topics tonight in men's health specifically. And like Brittany was saying, let's be interactive. This is for you all. I hope to shed some light on some topics tonight, and then I would love to hear what questions you guys have. So we'll start by talking about erectile dysfunction. What is erectile dysfunction? It's the inability to achieve or maintain an erection firm enough for sexual intercourse. This is something that is insanely common. Over half the men over age of 40 have some degree of erectile dysfunction. And as we get in our 50s, 60s, 70s, it would be actually more rare for you not to have erectile dysfunction. So just so you're aware, you're not alone in this situation. What is the normal erection process? There's three things that are required for the erection. Number one is you need stimulation. Number two is you need intact nerves. And number three, you need a good blood supply as well. So if any of those things are compromised, then that's when the erectile dysfunction forms. So for instance, the top three things are vascular disease. So if you have heart disease, congestive heart failure, heart attack, those that'll affect your blood flow and affect your erection. Diabetes is another one that's very common. Medications can do it. Any type of treatment for prostate cancer. If you look over to the right there, there's other problems that cause the erectile dysfunction as well. Pelvic surgery we'll get into, a neurological disorder, endocrine such as low testosterone. Other times just we don't know. And another thing too is just aging. You know, Father Time is undefeated in terms of erections. Just wanted to quickly touch on the erectile dysfunction and the connection with diabetes. Diabetes is something that's incredibly common, and it affects over 15.3 million men in the United States, and that was a 2015 consensus. I'm sure it's even higher now. The reason why diabetes causes issues is because remember I told you those three things that it can affect. Of the three things that you need for the erection, it affects two of them. It affects the nerves, and it also affects your blood supply. You have excess sugar molecules in your bloodstream, and those act like little rockets and cause destruction to those nerves or to the blood vessels. Therefore, that can affect your erections. Another thing too is that not only does diabetes cause erectile dysfunction, the other thing to keep in mind is that someone may have erectile dysfunction, and that might be the first sign that you actually are getting diabetes. So just keep that in mind. Same thing with the heart disease. Heart disease, when you have a heart attack, congestive heart failure, any type of vascular blood supply issue, that can cause erectile dysfunction. But again, just like the diabetes, it also might be a precursor, meaning you have the diabetes. You have the erectile dysfunction. 2 to 3 years later, you may have an issue with your heart. So just keep that in mind. Another connection I wanted to make here is that erectile dysfunction and low testosterone. Low testosterone is when a man's body doesn't produce as much testosterone as it normally does. This is very common, just like with erectile dysfunction, approximately 4 in 10 men over the age of 45 have this. It's also increased when somebody has obesity, diabetes, high blood pressure, those things listed to the left there. So the more medical conditions you have, the more likely you're going to have low testosterone. There are ways to treat the testosterone. That's something we do at our clinic as well. There's gels, patches, injections. There's actually some pellets as well. The biggest connection with erectile dysfunction in terms of the treatment for it is usually younger patients below 45. If you have low testosterone and you increase it, we give you replacement therapy and you increase it, it will help you, number one, with your libido, which is your sex drive, but it also can physically help with the erection as well. Usually in older patients who have other comorbidities, such as the high blood pressure, cholesterol, et cetera, the testosterone is more just to help with the libido. It doesn't necessarily help with the erection part itself. I have a lot of patients come in saying, hey, I was taking testosterone, my erection didn't get where I wanted it to be. That's because there's other players at play there. And so just keep that in mind though. Another connection there between erectile dysfunction is prostate cancer treatment. As you can see, when your prostate has cancer and it needs treatment, the nerves that wrap around the prostate, it's called the neurovascular bundle here, These wrap around the prostate. When you have to remove the prostate, you can affect those nerves there. And also that happens if you have radiation as well. So it's one of those things that sometimes people get prostate cancer, prostate removal surgery or radiation. And sometimes the cancer doctor doesn't necessarily talk about, hey, how do we fix erections after that? So just keep that in mind. There are ways to fix this if you have treatment for any type of cancer, not just prostate cancer, but also other pelvic cancers as well, or pelvic surgeries as well. And this affects anywhere from 25 to 75% of men after radiation or after the surgery. I think it's closer maybe to 65, 75%. And again, just it's one of those things that just making you aware that these are very common. Erectile dysfunction is very common after prostate cancer treatment. Peyronie's disease is another cause of erectile dysfunction. What is Peyronie's disease? This is when a fibrous scar tissue occurs inside the penis, and then it causes a painful curved erection. It prevents people from being able to have intercourse because they have a curvature. It doesn't allow as good blood flow to the penis, so it can affect the erections. It decreases the size of the penis. And the other thing is it causes distress. It creates a mental block up here because they're seeing this deformity. So it's very important that, if you're talking to a provider about erectile dysfunction, let them know if you have a lump, bump, or curve. This is something that can be fixed. One of the treatment options is Xiaflex. That's an injection where you can inject that into the actual scar tissue. And then over time, you're able to help the bends. Also, there's other procedures, minor procedures that I perform that can also help out. And also, though, if you have erectile dysfunction and Peyronie's disease, a penile implant, which is something I'll go into here in a second, that's something that can actually treat two birds, one stone kind of situation. Just a quick side note, the AUA guidelines suggest that some of these treatment options that are listed here are considered investigational. You might see on sports radio, even on the late night news or infomercials on the radio, you might hear something called extracorporeal shockwave therapy. That's where they use acoustic sound waves that hit the penis there. And the goal is to create an inflammatory reaction, but then that should lead theoretically into new blood vessels, which would then create a better erection. That is just saying everything is a nail and we have a hammer. As we've seen, there's many different reasons why we have erectile dysfunction. This is just in theory something that potentially could work. A lot of the data out there doesn't suggest that this does work. I think it has maybe a small role in a very select few amount of patients. Just be wary of that because they market very well for it. And it's very, very expensive. And a lot of people come in saying this didn't work, and it doesn't surprise me. You also might hear about these two injection therapies. One is this stem cell therapy or platelet-rich plasma. Again, this is not, I've seen zero data to really suggest that this truly works. So just be wary of what you're potentially seeing. Talk to a specialist, talk to a urologist that goes by, AUA or urological back guidelines if you have any questions about these things. Now, what treatment options are urology backed? What treatment options are insurance backed? And that's for the most part insurance backed. This is these treatment options here, and I'll go into each one of these. So anytime we have erectile dysfunction, we always start with the medications first. You've heard of these medications, Viagra's, the Cialises, Vitra. These are the type that can be very, very effective. And like I said, always our starting point. Overall, really well tolerated and safe to take. It's just a matter of when the erectile dysfunction is on a spectrum. And when we start off with erectile dysfunction, they're very, very, very potent and they work very well and patients are very happy. But as their erectile dysfunction moves on, they might get worsening diabetes, high blood pressure, the aging process, all those things that we listed before, then the pills don't necessarily work as well. So that's not uncommon to hear. A lot of times people are like, well, this one didn't work, but let's try the next one or the next one. That's kind of just kicking the can down the road. It's not really, you're at a point where the erections are just no longer going to be receptive to the medications. This is something called intracavernosal injection therapy. This is just a fancy way of saying that we draw up a liquid medication that's more potent than the oral medications, and then we teach the patient how to inject it into their penis. It is something that does take about 10 to 15 minutes after the injection to kick in. It does give a good erection, and it's definitely a worthy option to discuss for completeness. I will say that despite the success of getting the erection, 40% of men discontinue the therapy typically within 6 months. Data now suggests that only about 20% of men after a year continue with it, and then it just dwindles down from there and there. The main reason is because number one is it can cause you may not get the erection that you're looking for. And so that can create a performance anxiety up here. And if you're thinking about, man, I hope this works well this time, but it doesn't, then it may affect what happens downstairs and in terms of getting that rigidity. It's also not the most fun thing to poke yourself each time into the penis. And it's also one of those things that it creates some scar tissue, and it can create even porones and whatnot. So another thing too, it's actually not covered by insurance. It is relatively affordable, but just be wary. It's definitely an option worth looking into, but it does have its pitfalls. This is the vacuum erection device in the penile ring. The vacuum erection device, as you can see on the slide picture there, is a hollow tube, and it has a suction at the end, and then you put it over the penis before intercourse. When you activate the device, it brings blood flow in from the pelvis into the penis. And then once you get that blood flow into the penis, you can place a ring around the base of the penis that traps that blood in there. This is something that the way I counsel patients on this option is that if you're getting a good response from the medications, but you want a great one, this is where this comes into play. However, if you're not getting any response at all to the medications, I can tell you just with years of experience with this is that it tends to be a waste of time, money, and effort. But it's one of those things that is an option for us. This is an outdated method here. I just included it for completeness sake, but this is something that's not distributed. Just wanted to include for completeness. Now, this is something called the penile implant. As I alluded to earlier, this is something that is actually considered the best long-term solution to erectile dysfunction if the pills don't work. And I'll explain to you why. It's over a 98% satisfaction rate for the patient and their partner. Over 95% said they would still do that again if they were faced with that decision. And what I wanted to do was show you actually how it works. Then we'll talk about the pros and cons, and then some logistical things about it, and then we'll take it from there. So what I wanted to do first was show you a schematic of how this works. Okay. So what we do first is we make a very small incision. This incision is paper cut size, very, very small. It's either above the penis or in between the penis and the scrotum there. And then I'll show you the internal portion of the device here. So when before patients have erectile dysfunction, normally how you get an erection is there's two blood chambers that are shaped kind of like hot dogs here. There's two blood chambers that fill with blood and give you a natural erection, but now we're not getting that erection anymore. So there's two cylinders then that are placed, one on each side of the penis. And then there is a pump that's placed inside the scrotum. And then there's this reservoir that's placed behind the pubic bone. This is something that is never felt. The incision, everything is placed to that one little incision we discussed right above. And then the other thing is that there's tubing that connects the reservoir to the cylinders, and then tubing that connects the cylinders to the pump as well. And I'll explain what that means. So when you want the erection, what you do is you just simply press the pump there, and the fluid from this reservoir goes into the cylinders and gives that nice rigidity there for you. Once you have this pumped up, this looks and feels like a natural rigid erection. It does not change your sensation. It doesn't change your climax. It feels natural to your partner as well. You can keep this up as long as you want. You can even have a climax and still keep this rigid. This is like a superhuman power. And then from there, when you're done, what you'll do is simply deflate this here, and all the fluid goes back out of the cylinders into the reservoir there. And just for completeness, this is something that is completely internalized. You can't see it from the outside world. And I'm actually, now that I've showed how the internal workings of this device works, I wanted to show you on an actual patient. And just be aware, this is a nude patient, but it's for completeness sakes. This is something that really shows how this works for us. So as you can see, tiny incision up here that'll eventually fade away. The device is completely internalized. You can't see it from the outside world. He finds that pump there, as we were talking about, and all he does is simply just keeps pumping the fluid. That fluid from that reservoir then goes through the cylinders there and gives him that natural, rigid-looking erection. And this is something, this is slightly fast forwarded, but honestly, you could see how quickly that erection was obtained. And as you can see, that's a natural rigid erection. You can look at him and say, hey, you have a device inside. That's how it looks for everybody. So, and the other thing too is you saw that he had a ring on. Just like that ring, if you wear a watch or ring, you get so used to having the device in, you get so used to having that ring or watch on that you forget that it's there. And that's how this device becomes too. It becomes a part of you. So very natural look and feel. And also you get very used to it. Again, he finds that pump, pushes the deflate button. He finds it there, and then he'll just squeeze that fluid out here, and it just deflates back down. And then that looks like a natural flaccid penis when he gets back down to that deflated state. So this is usually, it's usually performed as an outpatient procedure. It's one quick procedure, lasts anywhere from 35 minutes to an hour. And it's very well tolerated. Small incision, again, above the pubic bone there and the scrotum. Takes a couple days afterward you go home the same day, but it takes a few days to return to your regular routine of light activity, just no heavy lifting or sexual activity. And about 4 to 6 weeks before you can start using the implant. But overwhelming majority of our patients within 4 weeks have the device in, they've completely healed up, and they're ready to use the device. Insurance does cover this. Sometimes the private insurance will say no, but we will tend to fight as much as we can for the patient to get it covered. And then overwhelming majority of time, I've rarely seen Medicare not cover it. And then the other thing too is don't let cost be a barrier. I mean, the treatment can be affordable. There's always ways to get these payment plans going too, if you're interested, and the insurance is being difficult. But at the end of the day, this is something that is very affordable, and insurance covers. So let's talk about the benefits, and then we'll talk about the risks. The benefit of this is that they're, like I was saying, over a 97% satisfaction rate, 98% partner satisfaction rate. Like we talked about, it's affordable. This is a permanent and concealed solution. It's durable. It lasts anywhere from 10 to 15 years. I took one out the other day that had been in for 29 years. That's the exception to the rule, but it's just showing you how durable these are. It's very, very natural, as you can see. It's the natural erection, natural flaccid state. It does not interfere. It says typically doesn't. I've never seen it really interfere with ejaculation or orgasm. And the biggest thing about these devices is, number one, is you get that spontaneity of sexual activity. When you're able to get that spontaneous erection, that gets you and your partner excited about sexual activity. Unlike with some of the other modalities to help treat it, you have to sit there and wait for them to kick in, and then it kind of can lessen the mood. So whenever the mood strikes, you're ready to go. The other thing is that there's no performance anxiety, because the device does the work for you. You don't have to think in the back of your head, hey, is this going to work this time? It's going to work. And so that really gets people excited again about that. And the other thing that we've seen is that when people aren't able to get an erectile dysfunction, it creates a gap in the physical intimacy of the relationship. Hey, let's not do this tonight. We know it's not going to work. Let's just hold off. And then you stop doing it and you stop talking about it. This is something that bridges that gap. This is something that gets the sexual activity going again, because you're able to perform on demand and consistently. And we have a finite amount of time of having sexual activity on this planet. So why waste it on other things that may or may not work? This is something that will work and get you, back into the physical intimacy of the relationship again. And not only does it help with the intimacy of the relationship, it helps patients with their confidence. I hear men all the time say they feel like they've lost their manhood, or because they can't please their spouse. They like that confidence that comes with getting that erection. And so that is something else that it helps out with as well. So now, unfortunately, nothing's perfect in surgery, although it's a very, very high success rate in the 95% plus, 98% plus. There's always a risk. The one risk is that it's going to have some temporary discomfort afterward, but that is something that comes along with all minor procedures. There can be a mechanical failure of the implant. That just implies that there's a leak somewhere in the system, and that normal saline, which is a completely safe solution, can leak out. And if that happens, though, it's just like a flat tire. You just take it out and put a new one back in. The other thing is that there is a risk of infection. This is mainly for people who have diabetes. And it's lower, and it's still very low with a controlled diabetes. It's more of that 2.5%, that 3% when somebody is uncontrolled. But for people without diabetes and controlled diabetes, we're talking about closer to the 1%. So, but again, if that happens, we take it out, put a new one back in. Just a quick summary: erectile dysfunction is very common. No patient is alone out there. This is something that's incredibly common. As we talked about, there's a variety of treatment options. And like we talked about with the penile implant, long-lasting solution that is a very, very high satisfaction rate. All right. I want to switch gears a little bit, and I do want to talk about urinary leakage. Urinary leakage what is this? This is when someone cannot stop the urine from flowing out of the body, especially when they move, laugh, cough, sneeze. This is also a very, very common problem, especially in men who've been treated for prostate cancer or those pelvic surgeries, and I'll get into that. And it's something that is worthy of discussing. And just quickly, the normal anatomy. This is our bladder here. This is a side view of your body here. This is your bladder that fills with urine, and then the urine goes through. This is actually your prostate, but the urine channel goes through the prostate, through the sphincter here, which I'll explain in a second, and then through the pee channel and out the tip of the penis. There's actually two sphincters. Only one is notated here, but these are two sphincters, or two barriers that keep the urine inside the bladder, because if we didn't have those sphincters, urine would just form in the bladder and then just immediately pop out. So, but once your bladder is full, the sphincters relax, allow the urine to come through, and then those sphincters then close back off. Like we were talking about, this is strongly correlated with prostate cancer surgery. And like I said, sometimes people get the surgery done, or they might get it out of town. They might go to Mayo Clinic or something, and they go back to hometown. They didn't get a chance to follow up with the oncologist regularly, or sometimes the oncologist just doesn't tell them, hey, we can fix this. So just keep in mind, there is a solution if you need it. About 9 to 15% of men have incontinence for 1 year after treatment of the prostate cancer. But there's other things that can cause the leakage. I see this all the time, where it's a result of a neurological disorder such as Parkinson's. They just their sphincter doesn't work well because they have a bad communication between the bladder, the spine, and their brain. But that's something that can occur in enlarged prostate surgery. If someone has the rotor-rooter or some type of destruction of the tissue, the sphincter could get into play, or the bladder can kind of overreact and create this leakage. Radiation can do it, and also pelvic trauma. So there's different ways that this can also happen. But again, it's just something to be aware of, that it can be fixed, because stress incontinence is something that can really affect your quality of life. People don't want to go out in public. They're leaking themselves. That causes psychological distress, and completely understandable. So we have solutions. And again, we've already touched on this. When those, this schematic anyway, what happens though is when we remove the prostate, specifically this one right here, you lose one of those sphincters, because you have to take the sphincter with you with the prostate, because you don't want to leave prostate cancer behind. But you do have that one sphincter that's downhill, and that will actually come and help, recruit and start to be able to get that leakage under control. That one remaining sphincter takes over what both of them used to do, but it can take, it can take up to a year to get back to that. And then if you continue on, that's where the next few things come into play. There are some short-term treatment options for this, some behavioral therapy. Some people reduce their fluid intake because they're like, hey, if I drink more, I'm going to leak more. Doing that, though, can be bad for your kidneys. They plan their restroom break. There's some Kegel exercises or some physical therapy that can help. I've seen these. If someone's going to leak after a year, these things are great to do, but I've seen it not work very well. And then there's other coping mechanisms. You're not treating anything, but you can wear a pad, some diapers, or even clamps and catheters. Those are designed to help just collect the urine or just prevent you from getting wet, but it doesn't fix the problem. And these are, when people are using these routes, it can be really expensive. I have a lot of patients say they're like, I should start investing in a diaper company because of how much I'm buying. And it's one of those things that it can be very costly. So what are some long-term solutions to this? One of them is a male sling, and I'll show you a picture of that in a second. But just like with the penile implant, it's something that is undetectable. You can literally look at you and you can't tell that it's in there. Has a very high success rate. They're very, they get that leakage under control right after the procedure, and a very high satisfaction rate. Basically what happens is that it's a minor procedure. There's an incision that's made in between the scrotum and the anus, and then we're able to look at your urethra tube. And from there, what we do is we put the sling underneath the urethra. If this is your urethra or your pee channel, we're giving this extra support, like it's acting like a hammock. And it basically allows, when you laugh, cough, sneeze, instead of the urine leaking out downward like this, the hammock catches it and it doesn't allow you to leak. But then when you want to use the restroom, you're able to push your bladder will push, and then it'll overcome the sling and pee when you want. But you urinate just like you have your whole life. You would just go up to the toilet and and urinate when you decide you want to. This is something that is, back to the sling, this is something usually designed for people with mild to moderate leakage. I want to talk to you now about an option for somebody who has more severe leakage. This is something called an artificial urinary sphincter. This is considered the gold standard. This is also like the penile implant and like the sling. This is something that's a discrete bladder control. You cannot tell that someone has this device in. It mimics what that healthy sphincter does. Again, we have a barrier that closes off naturally and doesn't let the urine escape. However, if the remaining sphincter isn't able to keep that urine in, we actually add an artificial sphincter back to you. And I'll show you how this works. And basically, I'll show you this quick picture, and then we'll see a little schematic there. But there's a cuff that basically wraps around the pee channel and then closes it off. And then, similar to the implant, you have little 3 components to the device. There's a little fluid reservoir here that holds fluid in there. There's a very small pump that goes inside the scrotum, and this cuff that wraps around the pee channel. And I will show you how this works. And it's a similar incision to the sling. It's not pictured here, but there'd be a small incision that goes in between the anus and the scrotum here, and that's how we access the urethra there. As you can see, though, there is a cuff that wraps around the urethra tube. This is filled with fluid, and that fluid then compresses the pee channel down. When you want to urinate, all you do is push this button there, just like that, and it opens the channel back up. It's like opening a garage door, allows the car to leave. This is like opening your pee channel up, allowing the urine to escape. And then due to the pressure regulating balloon, the fluid will then actually just automatically cycle back through and then close the channel back off for you. So it's a way to create a barrier system, prevent that urine from leaking, and it helps those men with the low quality of life because of that. Another outpatient procedure, just like the sling and the penile implant, very small incisions. it takes a few days to return back to non-strenuous activities. You can sit, walk, stand as much as you want. Same with the implant, same with the sling. You're not bedbound by any means. You're able to get back up on your feet. Just no heavy lifting. We just don't want you going to run a marathon or do, crazy squats or something like that. And then after about 4 to 6 weeks, we're able to get that activated. We can't initially activate it just for healing purposes, but once you're healed up, we activate it. That's something we do quickly in the office, but just an FYI. So you would leak for a couple weeks after, like you normally are, but then you're able to be dry right after. So over a 94.6% satisfaction rate. Over 90% of the patient would have surgery again. I can tell you, someone who goes from being wet to dry, those are some of by far the happiest patients that I see. Also, similar to the penile implant, covered by insurance. It's something that is overwhelming majority of time is covered. And the benefit is you're able to achieve that incontinence. You urinate when you desire. It's invisible to the outside world, high satisfaction, and it just gets you back to your normal life there. Just like with anything, there's always risk, but not all patients are candidates. Sometimes, they have a very, very, very complex urethral history or radiation, things like that. But in general, most people are. There's always a chance that the device, for instance, the sling, may not work like we want it to. It can make you go into retention. There is some post-op discomfort, but these are all things that are something that these are low percent chance. We just have to let you know. And same thing with the artificial sphincter. It can cause malfunction. It can cause retention of urine. The cuff that's wrapped around the PE channel, it can erode into the actual urethra, and that have to be removed. But these are things that no matter what, they're very high success rates in the first place. But if anything happens, we're always able to fix. And just a quick summary, there's these, the leakage is a known side effect of prostate cancer treatment. There's a variety of treatment options. These short-term options or something that is just kind of putting a Band-Aid on it, and they can be expensive, but the sling or the sphincter is something that if you have any problems, I'm more than happy to help you out. That's what I do all day, every day. So just some references there. And but yeah, I want you guys to fire away with questions. I'm available for you at any time. My office number is, if you call this number here, you can just ask for me. They'll know who to send you to anyway. They also have a direct number too. It's 615-622-5039. Again, 615-622-5039. That gets you directly to my team. Or if you call this, they're more than happy. But I hope this helped. Again, I love talking about this. I'm very passionate about this. My goal is getting people to talk about it, getting people, mentioning this so they understand that they have options. And so I'm here to help out, and let me know if you have any questions.